Well, good evening, everyone. Thank you all for joining us for another exciting discussion on health and wellness. And tonight we're going to discuss aging well from a mental health perspective. We've covered the topics of, caring for ourselves from home with diabetes. We've talked about how to begin the journey to better health and wellness. And so we've been hitting that health and wellness button all year long. And so now we're going to really focus on the mental health portion. We don't hear a whole lot about that. We always see the advertisements for, go to Planet Fitness and eat right and build your muscle and get the perfect toned body. But rarely do we hear a lot about how to take care of ourselves from an emotional and a mental standpoint. So I'm excited to have Gary Davis, the Business Development Manager of the Williamsburg Place campus, and he has prepared an awesome presentation for us. And so without any further ado, Gary, take it away.
Thank you very much, Miss Janae. I appreciate that. Good evening, everyone. I hope you can hear me. I'm working and operating out of a hotel, so it's always nice to have webinars that are good for travel as well. So if you have any problems at all, please do let us know in the chat room, and we'll be sure to get them addressed for you. So as was mentioned earlier, there's a lot of things about aging well from a mental health perspective, and we're going to talk about some things today that are just hopefully get you thinking in a different direction about mental health and the aging process and how they relate together and why it's so important that we really should focus on this just as much as anything else that we're focusing on. And we will talk about some nutrition, and we'll talk about vitamins and all kinds of things, but our focus here tonight really is going to be trying to pull this together and make it something that you can take with you and think about. And I do have a little bit of homework for you at the end of the slide, but I promise there's no test. So we'll be able to get through all of that and give you something to think about and maybe take home with you as well. So I want to give credit real quick to my very good friend, Brian Clemens. He and I have served together on different committees and different boards and in different areas in mental health the last several years. And so he is the program director for the Bridges Inpatient Unit and the outpatient units for Rappahannock General Hospital. So Brian was an instrumental gentleman for me in helping putting some of these thoughts down on paper and getting this where we wanted it to be. So thanks again to Brian, and here we go. So some of the things we'll get into in just a second, but the views, what we talk about here are really kind of my thoughts and Brian's thoughts. I mean, we're not going to lie to you, but these are really just kind of our thoughts about what's going on out there, but it is information. So I'm not going to give you a full 7-year medical course and get you to, feel like you can do surgery tomorrow morning when you get up. So we did a lot of different research pieces, and we'll share those with you as well. So the whole person, when we look at ourselves from an aging in place and aging well from a mental health perspective, one of the things that we really look at is the whole person. And that is the biological and physical aspects, the psychological aspects, and the sociological aspects. All of these work together towards how we age and how we think about ourselves as we age. So these are going to be some of the things we're going to talk about first as we move through our presentation. So physical activity should be no surprise. We often have heard that 30 to 45 minutes a day of some type of cardiovascular exercise is always optimal. Doing it 5 days a week if at best. Exercise should always be done in accordance with how the physician feels is the best plan. Sometimes from the healthyaging.com website, they recommend that even exercise at that time frame, even if it only burns 150 to 200 calories, you're moving in the right direction as far as keeping that physical activity up and going. So as we get older, we know that our bodies tend to slow down, we get weaker, we're more prone to infections, our metabolism slows down. So anything that we can do to keep ourselves active and keep moving is not only physically but emotionally good for us as well. That old saying of getting outside and getting a breath of fresh air is always important to be able to do. And then again, simple activities like walking and gardening and biking, stretching, things of that nature. Even swimming is a great exercise if you can do that. So keep that in mind as we go through, and physical activity is very important when it comes to mental health. So again, I'm not going to give you too much on the nutritional side because I think you've covered those in some of your last presentations and have had a lot of information about it. But two pieces that we really wanted to employ here are vitamin B12 and vitamin D. And the reason for that is that both of these are absolutely known in the mental health world of having some serious effects when there's a deficiency in a vitamin B12. So B12 is really instrumental with helping with memory. So when somebody is lacking B12 or they have a vitamin B12 deficiency, it can actually mimic the effects of aging. So it looks like somebody's getting older and acting older than they really are. So some of the things that B12 helps us do is it helps us form red blood cells, and it also, the deficiencies can lead to types of anemias as well. And all of that causes fatigue, confusion, drowsiness, lack of appetite, lack of motivation to really get off the couch and get moving at times. And it's really needed, vitamin 12. B12 is needed to support the normal function of nerve cells. And it helps manufacture things within and around the nerve cells. It helps speed up the neural transmission. So in our hospital at the Pavilion, when we treat our mental health patients, and especially our geriatric population that comes to us for care, this is one of the first things that our geropsychiatrist and the treatment team will look at is a B12 deficiency, because if we can get the B12 levels back up, they can actually do really well. And not everybody has to have, this full-on medication regimen that hospitals and providers like to provide at times. And the last piece of that, vitamin B12 is required for the replication of our DNA. So it's actually a very, very important vitamin that our body needs just in order to function as a body too. So because vitamin B12 is normally absorbed, it can be received in the B12 type injection. So that is something that we do in the hospital setting as well, as we give those folks that do have a vitamin B12 deficiency, we give them injections as prescribed by the physicians, that way they can carry that with them when they're discharged from the hospital and continue to receive the vitamin B12. And over time, what we're trying to do really is help them with that memory loss or cognitive impairments that they may be struggling with at the time. So my recommendation on B12 is just to discuss that with your physicians if you have concerns about just feeling less than yourself at times. Not always is it a mental health issue, and we'll talk about that a little later, but it's important to understand that there are some key vitamin deficiencies that can cause these as well. And to hit some points on vitamin D, as in David, vitamin D is needed throughout all of our cells in our bodies. It was a couple of years ago that it was the study was done to say, well, vitamin D only affects the bones, or it only affects certain cells within the heart for heart structure when there was a heart attack. Well, now even more research has found out that it's throughout our whole body that vitamin D is needed. So when vitamin D deficiency are present, they work against or they actually increase the risks of heart disease and Alzheimer's, along with weak bones and even diabetes. So these studies now are starting to show more and more pronounced information in regards to how important vitamin D is to the body. And vitamin D deficiency is deemed right now as a global epidemic, where there's an estimated 1 billion, that's with a B as in boy, people who do not have adequate levels of vitamin D in their systems. And in America alone, a 64% deficiency within the population. So this is something that is really starting to grab the attention of researchers and even physicians in general when we're looking again at mental health and aging. And so as we get older, what are the levels of our B12 and vitamin D in our systems, and can we combat that with injections or vitamins or other types of regimens that can help us increase those levels? So something to think about, a little food for thought there, if you will, on in regards to our nutrition is very, very important when we talk about mental health. If there's any type of weight loss that's going on, slow and steady wins the race. That's kind of always been the staple in weight loss. And again, portion controls and lower carbohydrates, things like that are always going to be beneficial for that. But, losing 20 pounds in 2 weeks is not nearly as healthy for you as it is to lose those 10 pounds in 2 weeks. So a slow and steady weight loss is a good plan. We give recommendations on a 2,000 calorie diet, including 2.5 cups of vegetables is always good. Lower salt intake and lower fat intake, and tend to eat what's easy and not good. So that statement really is a true one, and we just try to go with whatever's convenient for us at the moment of the day. And if we're busy with grandkids or we're busy with our friends and we're out and about, it's certainly a lot easier to grab maybe a soda and a bag of chips or granola bar. I was just reading an article just a couple of days ago in regards to how convenient these foods are for us, but how bad they are for us, because anything that is packaged in a package already begins to not be so good for us, because it has to be preserved, it has to be fabricated in some way, so it has this really long shelf life. So fresh fruits, vegetables, and all those things that we've grown up knowing about the food pyramids and stuff still remains the same as we get older in our life, and as we're trying to protect some of that memory loss as we get older. So stages of life, they come in many, many ways. There's no one set way in which somebody can experience a particular stage in life. And that also goes to play in the fact of just stages of grief. There are different ways that people grieve, so there's no right or wrong way in these stages of life. In 1982, Dr. Erickson did a lot of studies on the 8 stages of personality development. And one of the things that we wanted to kind of talk about was, as people get older and they get a sense of mortality that begins to settle in with them, and some of that mortality just comes from major changes that take place in life, such as retirement. We were active, we were doing our job, we were making the money for the company, we were doing what we were doing on the factory lines, we were driving trucks, and then all of a sudden we're not doing that anymore. And now we begin to look at, how much longer do I have to live? It seems like an awkward way to present that, but at some point when people get to a point in their life when they retire, they really begin to look at things differently in a mortality kind of way. Maybe there's a loss of a death of a spouse or a close friend. That's a major change in the lifestyle that they were once living, and so that personality development can happen very, very quickly. And like I said, there's no right or wrong way on how these stages can work. And even a change in a social role. So that may be something where an individual is at home thinking and feeling like everything is going really well for them at home, and all of a sudden they're not doing well, and then they end up in assisted living or maybe a retirement community, and some type of social change takes place as well for an individual, and that makes it very difficult to get through those 8 stages of the personality development. And sometimes there's an overall end-of-life review that takes place where we begin to question and surface, what did we do, what didn't we do? Is there anything negative? Is there anything unresolved? Is there anything that I could have done better? And all of these portray themselves into this mental health perspective that, maybe we just didn't do as well as we wanted to. And when we begin to challenge ourselves on that, it's part of that stage of life. It's part of the integrity versus despair. So as folks get to the age of 60 and older, and that's certainly not an encapsulated number, it's an estimated number, but there's a lot of looking on their lifestyle now. There's a lot of looking behind and not always looking ahead. So more of the life behind them than what's to come. They say, well, I've got 60 years of life. How many years do I have left? And not the most positive way to get up every day and think of that. So the mental health perspective as we get older really comes into play when we begin to look at our own mortality. The reflection of life and review of life, very important, again, part of the stages. There's good times with joy, there's hard times, and the sense of accomplishment and self-respect, even during those hard times. We do take a lot more sense of accomplishment and respect when we've been through something very difficult and made it through the other side. And then there's mistakes with the forgiveness piece. This is really a big part of the mental health and aging well, is being able to let go of some of those mistakes that we just can't forgive ourselves for. And when we can't do that, when we're not able to let go of those and forgive ourselves and forgive others too, these continue to brew. So as we have changes, retirement, deaths of a close friend or a spouse, social changes, this really impacts the way we feel inside, and it continues to feed itself. So normal aging and the Institute on Aging and Others. So these are some things that Brian and I had kind of discussed before. We've always kind of discussed these, and what happens when we look at the aging process, and what are some of the potential losses that we experience, such as friends. Friends move, friends pass away, friends just stop talking to us for whatever reasons. Things like that will change. Mobility. We were walking and now we're in a wheelchair. We need a cane. We need a walker to help us get around. These are potential losses as the aging process takes place. There's short-term memory and income, need for sleep, more or less sleep at times, and overall health. Whenever we have a health concern as we get older, it just weighs. It has a tendency to weigh on us to think, is this how I'm going to die? Is this how I'm going to end my life with a cardiac condition or the cancer or something? And getting involved, lack of getting involved is really the loss, because we may not be as involved with our church, our local communities, our volunteer services and things, just because we're not able to do it anymore. And our reaction time, such as driving. One of the big things that we try to help the families with in the Williamsburg community is using the Riverside Center of Aging and Excellence and Lifelong Health, where they have a driving assessment that folks can get into, and they can take advantage of that and really help determine, do they need to continue to drive? Is it safe for them to drive? And a lot of that comes down to the reaction time and the ability to hit the brakes when they need to and hit the gas when they need to. And it's a very difficult loss, because now it's a loss of independence that comes with that. And again, on the other side of the scale, we see the gains, things that we've gained through life and through aging, and resilience and wisdom and patience. In retirement life, we're supposed to have free time, but I know a lot of people out there that are quote-unquote retired and still very, very active and very, very busy, enough where they say, I don't really feel like I'm retired. So, but it's supposed to be a potential gain as we get older. We get a little more free time. The quantity and quality of your memories, that's certainly a very good gain. You have more time if you have the free time in your life, and you're thinking about things more often, and you're remembering things that maybe you haven't thought of in many, many years. The ability to cope with stress, because you've experienced stress in life, and you can handle that a lot easier than somebody who is not in your age group sometimes. And there's life satisfaction when you can say, yeah, I did a pretty good job. I'm pretty happy with how things have turned out for me. And then, of course, there's eligibility for programs and services. There's always things out there for our seniors in the communities, and it's important to take advantage of those while you can. So just a couple of things on that, and we're not going to belabor the potential losses as much. I don't want to do this too much, but there are health and strength issues that people have, appearance and body language, or body image, employment and income. Retirement comes fast for some people, and the income doesn't last as long. One of the things that's happening now in the nation is that people are outliving their money. And so it really raises the question is, what's the right retirement age? If we don't have enough money in the bank, can we really retire? Independence, again, can you drive? Do you need help getting around? Can you make your own meals? Can you take care of yourself? And when you begin to lose independence, that's sometimes when we begin to really feel like we're losing ourselves. Like it's a potential loss that turns into a much bigger loss, because we lose some of our identity with that as well. The sense of being useful and helpful, and time structures, a lot of times time doesn't mean much anymore, and you don't really know if it's morning, noon, or night, and what's the difference. Friends and involvement become a loss because they don't come around as much, they don't say hi as much, they don't call as much, and if you're not involved, you're not going out and doing things that you once were. So these are really good examples of potential losses that happen. And then retentions, so there's lots of positive pieces here. These are actually part of the positive gains as well. But, we do have the cognitive capacity. So sometimes as we age, we can still remember a lot of things, and especially our long-term memory versus our short-term memory. But we also have other things that we experience too, such as, an older learning style. So today's math is not, yesterday's math, it seems like. And so helping the grandkids or helping one of your children with a project sometimes can be really difficult if you have a older learning style. So as we go down this list, we look at ways of immediate memory, long-term memory issues can come out and be present as well. And being able to adapt and being creativity is always a good thing. There's sexuality, and if it's in question or if it's not a sexual activity, as far as being sexually active, that's always the retention that kind of happens, and people feel like they can still continue to have a healthy sexual marriage and a lifestyle. There's lots of coping mechanisms that we learn through life, and sense of well-being and social awareness. All of those things, though, we still begin to retain as we age as well. But if these begin to slip, these are things that we look at from a therapeutic standpoint and say these are things that are causing some anguish, maybe anxiety, maybe a slight level of depression for people when they used to be able to do these and no longer can. So some more gains here are maturity and experience and frustration, cautiousness. I know a lot of folks that we work with are always cautious around us, maybe even untrusting at times because they're really not sure if we're there to help them or if we're there to take something else from them. So that could be confusion, but it also could be just them being overly cautious about their surroundings. There's always a sense of a need for achievement. I think we feel that even through our whole entire life, is that we want to feel like we've achieved something that's worthwhile and has been for the greater good if we possibly can do that. We like to have responsibilities and be reliable people and work and have high morale and lots of loyalty. So those things come as our seniors, if you will, or those that are aging, continue to go back into the workforce. These are great attributes that are brought into the workforce that really kind of are struggling to be there now. So there's a lot of responsibility and reliability that comes with that, and there's also the role model of saying, hey, this is how you get this job done, and understanding that from your perspective and your role that you've had in life. And so, again, the idea of more free time, I don't know if that's truly possible, but it is a potential gain if we play our cards right. We could have more free time later on in our life. So some of the things we do about all this stuff is acceptance. In the therapeutic world, we really do try to help people understand why it's important to accept things that we can't change at times and things that are happening with us. So some of that is the activity replacement. All right, so I used to run 10 miles a day, but I can't run anymore, but I can still walk, right? So I can change my activity. I can replace it with something else and just accept that that is now maybe my new normal routine. And that's hard because it feels like we're giving up an independence piece too, but we still maintain the identity of somebody who's being active. So we have to kind of weave our way around on how we accept things as our body changes as well. So giving ourselves permission to make the change. In that case, again, I can't run 10 miles anymore, but I can walk 5, and I can walk 5 3 times a week. And then by doing that, we are enabling ourselves to feel better about a decision that we struggle with because we're giving ourselves that permission to do that. And then we can push ourselves. So maybe I run, 10 miles at once, and then maybe I used to run 10 miles, but I'm walking 5 miles 3 times a week, but I really want it to be 4 times a week because I'm just not satisfied with that. So it's a goal, but you're pushing yourself to get that way. And of course, you receive the benefits of the physical activity, increased physical activity at that. And setting a realistic expectation. If you've had 3 back surgeries, 2 knee replacements, and gout in your left ankle, maybe walking that 5 miles 4 times a week, maybe that's not so realistic. So we have to look at our physical capabilities just as much as anything. But again, accepting the fact that this is maybe the best that I can be able to do, but I still have a goal and I can push myself, give myself permission, and begin to accept all of that. And then even making the adjustment in the lifestyle. So I love to walk outside, but when it's rainy and it's cold and it's snowy and all these other things, I can't do that. But I can go into the gym and I can walk on the treadmill, or I can walk around the mall with a group of people that I like to be with and things like that. So again, accepting that change in our life helps us mentally say, okay, I can do this, but I can do something else as well, and be just as happy with the changes if we accept those. And it's really hard when we are very independent and we say, no, I'm going to keep on pushing, I'm going to keep on doing that. But there really does there does come a time in our life when we just can't do the things that we once could do. So when we talk about selective mental health issues in later life, I think personally, before we get into this, this is really a difficult subject for people at times because this is something that we don't want to talk about. We don't want to talk about how we feel. Maybe we're not comfortable with talking about how we feel. And maybe we really aren't comfortable about our mental health status or how are we doing mentally? How do we think about things? How are we looking at things? And this can be a very difficult conversation in and around the family and the household. I mean, it's certainly not something we're going to bring up next month, if you believe it or not, for Thanksgiving. I mean, that's how you clear out the table. So we want to make sure that we can talk about it, we can be open about it, but we understand what is happening as we get older in our mental health. And so we'll talk about anxiety. This one's important. The National Institute of Mental Health, and that's the website quoted on the slide as well. Anxiety is a real condition, but it's a treatable condition, and it's a normal condition. So folks that are 60 years and older, 15.3%, have had some level of a lifetime long or newly diagnosed portion of an anxiety disorder, but yet it's still the lowest of any adult age group. So that means that those life experiences have kicked in, and you're able to have the coping mechanisms and the stress relief mechanisms to say, you know what, that doesn't bother me as much as it maybe once would have. So given the fact that anxiety is still very much a normal diagnosis as we get older, it's still not as prevalent at times in the older group, but it's there, and we do see that come through our hospitals. Part of our diagnostics that folks are coming into our hospital with. And women are 60% more likely to experience some levels of anxiety over the men. And I think that's pretty realistic number in the fashion that, they do have a lot of stressors in their life, and they take care of a lot of people after everyone and everything around them. And sometimes it's just like in healthcare, they're not looking after themselves as much. So I think that's where that 60% comes from, in the fashion that they have a lot of things that they put on their plate and they do every day, in and out every day, and they're not so quick to take care of themselves. And healthcare workers are just the same. If you know anybody that's been in the healthcare system, they jump right in, both feet, and they continue to go, 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 go. And when a significant medical change or a life change happens, they get really, they get shooken up by it, because they're kind of like, how did that happen? I didn't see that coming. That's because we were already on our train track towards that, and we just keep helping everybody else that we can. So it's important for all of us to take a lesson out of this one today and make sure we're taking care of ourselves and eating right and getting the good exercise that we need. Depression. Now, this one's a little bit more serious, because there's a lot of statistics around there that I didn't want to get into, particularly with this. And maybe I will say a couple of things about it, and that's not on the slide. But for those that are over the age of 50, 4.5% of this age group right now has a diagnosis to some degree of a depression, whether it be a major depressive disorder or some type of an adjustment disorder, or something along those lines. And maybe it's not even specified. Maybe it just doesn't even have a true classification to it. But, this is something that's very, very real out there. And there's a lot of different ways of handling the depression, but it's still something that we need to be able to recognize within ourselves and others around us, and know that, there are things that we can do to help people that suffer with depression. And women are 70% more likely than men to experience depression during their lifetime. And there's many reasons why that could be, but I think the most prevalent with that is just going to be, again, back to the anxieties. And if the anxieties aren't treated, sometimes they can lead into a depressive state. And it comes down to the empty nest syndromes. It comes down to, it could be retirement. It could be all kinds of things that create these depressive states for us. and it could most significantly for women too, is the death of their spouse, because women tend to live longer than men. So this can be a very acute, very sudden onset of depression that happens later in life, and people say, "Oh, I've never had depression." So when they get the diagnosis, they actually think that, this is it. This is it's all over right here. I'm never going to recover from this. But in fact, you can, and there are some great ways that you can do that. But that diagnosis has always been one filled with stigma that not everyone truly understands or even accepts. But it's true, it's real, and it's happening every single day, and we treat it every day, and people get better from it. So it's not a life-ending type diagnosis. It just needs to be dealt with appropriately. Dementia. Now, here's a word that if you've attended anything in the Alzheimer's Association organization speeches and things, dementia is just being thrown out there all over the place because it's really a broad-based term. There's so many different levels of what dementia means now that I think the diagnosis itself is just being stamped so quickly before we look into it. But that's my personal opinion. But the diagnosis is real. It's really being used a lot, 30 million worldwide right now. And we're in this zone where this slide says we'll double every 20 years to 80 plus million by 2040. That's very, very real. And if you live anywhere between Richmond to Virginia Beach, you know this corridor, memory care units, assisted living, and independent living units are coming up left and right to help ease some of the pain of the folks that need a new place to go and new levels of care to be given to them. So this is one of these issues that we're not out of the woods, and there's no cure. There's just strict management. It's about managing the symptoms and the behaviors and things, but it takes a lot of people to make some of these things happen for everyone. So we have a lot of work left to do in this corridor, and that number is pretty staggering, that 80 million by 2040. That's really not that far away. But every day it's a new diagnosis, and people are dealing with it. So I will just say this real quick with dementia and the Alzheimer's Association. They're a great resource for people who have a loved one at home or are suffering with it, maybe even slightly themselves, and trying to understand it and getting information and resources and education on it. The Alzheimer's Association is a great place to get that information, and they can lead you down so many paths. People think, oh, because it's the Alzheimer's Association, I have dementia, I can't go. But it's not true. It covers so many things along the lines of the diagnosis of dementia, not just Alzheimer's. And almost everything we do is kind of similar anyway, with the exception of some of the medication treatments and other modalities that we know about Alzheimer's. So in the end, the Alzheimer's Association is a great way to get resources for the dementia care. Average survival time with the diagnosis has been roughly 4.5 years. But that still encapsulates the folks that are in the diagnosis of Alzheimer's, which we know is a detrimental diagnosis that happens with the degeneration of the brain, and that does lead to death. Other types of dementia does not necessarily lead to death, but the average survival time is around 4.5 years. But that's an average based upon a UK study, so not a solid number to just judge that by. Diagnosed before the age of 70, most people on average will live about 10 years, and even longer. Women live longer than men. That's a known status, but even with the diagnosis of dementia, they do tend to live longer than men as well. If there's a physical frailty, so if there's osteoporosis, if there's muscle weakness, if there's cardiac problems, respiratory problems, things of that nature, death can actually happen even sooner than the 4.5-year average time span, just because of the physical frailties that happen with that. And with dementia itself, it really does wear down on the body. So with the physical frailty combined with the dementia diagnosis, it really can just overall reduce the life expectancy across the board. Anything can happen between those years, and in dementia cases, all too often people are trying to stick it out. The families are trying to work through all the things and keep mom or dad, grandma or grandpa at home, and a fall takes place, and then you have a much bigger issue on your hands, because now you have a physical frailty, you have a hospitalization, you have all these sudden changes that take place and can actually speed some of the processes up of the dementia in general, creating more confusion, agitations, and things like that. So there's a really, really broad stroke of this, but it all kind of works together when we're looking at how we take care of ourselves and some of the things that we can do to help ourselves stay healthy and hopefully try to avoid this as long as possible. So functional ability is the strongest predictor for survival and quality of life. That old saying, use it or lose it. So our activities are going to be, driven to help us keep sharp minds, physical bodies in good shape, and, healthy blood running through our body as well is all important. The functional ability of our body is just the greatest predictor for our survival. So one last note on the advanced dementia care. It's now a hospice-approved service under Medicare. And with that being said, if there are people that are working with folks in advanced dementia stages and they need hospice levels of care, it's approved. And you can get that as a hospital-based or you can get it as a home-based services that you need. So there's no need to feel as if you're just going to have to do it all alone. You can get help. You can enlist the people who do some of these things for you for a living, and if it can ease any pressures and pains in your life for having to care for somebody with advanced dementia, the hospice services are a great way to do that. And if you need resources, please let us know. We can help you get to them. Peninsula Agency on Aging is a great resource in getting connected to hospice. Your local physicians and hospitals, Centera, Riverside, Bon Secours, they all have hospice programming. And, it's there if we need it, and it's a good thing that there's so many levels of care that can be adjusted now. It's not just one box. It can be divided up in multiple things. So we're going to talk about the select causes of mental health symptoms in later life. So what that means, that title really means what can cause some of our mental health symptoms in life. As we get older, and the word polypharmacy just meaning that we have more than one medications or multiple medications, of course. As we get older, our body responds differently to medications. We don't process it as quickly. We don't digest it as quickly. Our liver doesn't break it down as quickly. And so when we're taking a medication, say every 6 hours, it may take our body, as we get older, 4 hours just to get it going. So when we couple that with another dose and then another dose, because we're being true to our medication regimen that the doctor has prescribed us, one of the things that happens is we begin to mix all these medications, and they have all these different side effects that start to take place. And then we, as a human being, no matter what our age is, once we start taking too many of those medications at once, they really do begin to start to contraindicate one another. So one's supposed to help you sleep, and the other one helps just to keep you awake. And then, we have all these different side effects that are going on, which affects us mentally because we become confused. And some of those side effects of those medications, if you've watched them on television, they have a long string of things that happens when you take this particular medication, these warnings. So as we get older, we can actually become more susceptible to those and creating even more problems rather than helping us as we get older. So it's important that if you have a lot of medications or you're dealing with somebody that has a lot of medications and they begin to just not be themselves, they're not happy, they're not as they once were, that you remember, take a look at going over those medications with a physician or somebody who's able to look at all the indications and contraindications that are going on with those, because that can really be a problem, just affecting the overall mental health. And there's no mental health diagnosis to begin with, so it could just be side effects. We don't know. And untreated medical conditions. So as people get older and they have high cholesterol, but they've not done any lifestyle changes, and they don't take any medications, and that continues to go. It's known in the studies that they can produce strokes, and there are things like vascular dementia that happens from strokes, so you lose a portion of your short-term memory and ability to remember things just through having a stroke. So unrelated medical conditions can happen and can affect us in mental health later on. And then delirium is an interesting term in and of itself, but one of the common side effects as we get older of medications can be delirium, and we begin to think things and believe things that aren't true, even to the point where some medications can cause hallucinations. So we see and hear things that aren't really there, but we believe that. We believe it with all our might in our body that this is really happening to me, and it's happening right here, and I see them in front of me. And so when things like that are going on, those are triggers to say, something else may be happening, and it's not always just because somebody has gone, quote unquote, crazy, if you will, or they're losing their mind, or whatever we throw that out there as. It could really be a side effect of a medication. So other causes of mental health symptoms can be infections. Most common infection that we know of in the mental health statuses for our older adults is the urinary tract infection. It looks and resembles almost like an acute mental health crisis, when in fact it's just it could be a bacterial infection that needs an antibiotic in a couple of days, and they return to being normal again. So when they approach us at the hospital for acute psychiatric care, especially in the geriatric population, these are things that we want to look for specifically because we want to make sure it's not an organic issue and that it really is a psychiatric issue that's going on. So withdrawal, people who take a lot of medications and then stop taking them all of a sudden can have withdrawal symptoms just like an addict would when they're using substances. They get sick and they feel ill and they kind of become a little delirious, and delirium begins to set in. So again, that narcotic base in the older population is really an issue that is being talked about a lot. So something to look at if somebody's been on a narcotic-based pain medication for many, many weeks, then all of a sudden they just stop taking it. It could be symptoms of a withdrawal symptoms that they're experiencing and not necessarily mental health. Acute metabolic changes, so at one point, our metabolism is moving and then all of a sudden it doesn't move. And that could be really in the stomach and the intestines, and that really creates other types of issues that are medical, but really look mental at times too. Any type of trauma, central nervous system issues, any type of apneas, folks with sleep apnea that have a CPAP or a BiPAP prescribed but don't use it. Obviously they're not sleeping well, maybe, or as well as they could if they use their machine. So, and anybody has a low oxygen level too. Any types of deficiencies, such as what we mentioned, the vitamin B and 12, endocrine problems, also related to types of diabetes and things of that nature. Acute vascular problems, again, strokes or history of strokes or many strokes. Toxins and heavy metals. This is something that I did not think of, but I thank my buddy Brian to bringing this out in the fashion that people who used to work in the shipyard were exposed to lots of toxins and heavy metals over a period of time, and maybe the protection levels weren't as stringent as they are now in those environments. And are they experiencing any kind of later in life stages that are show mental, but are actually a medical condition as well? And of course, substance use goes without saying that the more we take of these medications at times, the risk is always going to be there that we can become addicted to them, or we just have to have them all the time, and so when we are taking things longer than we should, we can also have problems with our physical and mental well-being as part of that process. So the treatment and management in the broadest sense, really there's a lot of things that can be done, but one of the things that we want to talk about today is hitting the point in regards to advanced directives. The Virginia Department of Aging, the Virginia Department of Mental Health, elder law attorneys, and other folks that are out there can help with these advanced directives as we get older. And the Virginia state law changed in 2009, allowing for the mental health component to be a part of an advanced directive. And what that really means is Virginia has some really strict ways of people being admitted for mental health reasons to a hospital. And sometimes that looks as if that individual is being arrested because a temporary detention order has been put in place by the magistrate of the local circuit court. And the local community service board is the one who asked for it because at some point during the evaluation, the individual being evaluated lacks capacity to make a decision for him or herself and can appear to be a harm to herself or himself and others. So when that is deemed that the capacity is no longer there to make a decision, the state issues a temporary detention order, and then they will arrive to our hospital or other hospitals around the state via police or sheriff's car. Whereas the mental health component in an updated advance directive allows somebody to sign you in, or her in, him or her in, to the hospital without having to do all of those steps. And those steps that Virginia have are necessary for safety of the individual and others. But it really does look like someone's being arrested, and it's very confusing to someone who has dementia or mental health illness. And even though there are people who are familiar with the TDO process that the state has in place, it's not a perfect process, and the mental health component in an advance directive really cuts out a lot of that traumatic experience of going through a mental health crisis. And the advance directives can always be updated as long as the person is of sound mind. It's a legal document, and if the capacity is there to make decisions for yourself or for his or herself, they can also revoke it. They can change who they want to have the powers of attorney and be in control of their finances to their health care. But as long as that person is of sound mind, the advance directive should always be looked at as a means of how do you manage a mental health emergency or behavioral health emergency as we get older. And the review is always indicated anytime a change in level of care occurs. So as we give those powers to people that we trust and our loved ones are looking after us, whenever there is a change, we need to make sure that we're also reviewing the powers of attorney and that any changes that need to be made are made appropriately and in a duly process. It doesn't help if you don't have a financial power of attorney that you needed on a 6 or 7 or 8-year-old power of attorney, when today we need some financial decisions to be made. So it's always important to keep those up to date. In the aging well and the mental health perspective, the overarching considerations that we like to talk about and just continue to push to the communities is the hope. The hope that this can be dealt with, this can be treated, this can be managed, this can be better if we get the help that we need. And the choices that we make and the empowerment that goes into making the choices and the community focus. There's a lot of work happening in Williamsburg right now, and even all the way down to Virginia Beach and Richmond and at the state levels, and there's a lot of community focus going on. And some of the things that happen is the connectedness that people are coming in together saying, I know who you can contact to get the level of care that you need. And that just kind of feeds right back up this consideration chart, if you will, to hope. You had a situation that you didn't feel like you were in control of, but now we can help you get connected to the right kind of people, programs, and placements and things of that nature to help give you the hope and enable that choice and empowerment, community focus, and connectedness. All rolls together. And as we get older, and unfortunately in this communities that we're living in, these are always going to be considerations that have to be dealt with as we go through these crises, because it's happening and it's going to continue to happen. And so from a mental health standpoint, we understand that completely, and we continue to just try to give people the right types of information to help make good choices. So there are types of providers and levels of care, even when there is a mental health component, such as, say, a diagnosis of dementia. So in-home care can be formal or informal support, and those levels of care are normally done and based upon assessments. So once somebody is assigned to come out and make an assessment, they will help formulate the plan as to what's going to be the best level of care that's needed. And there's multiple layers and levels of care, and I truly believe that most of the home health care agencies that I've worked with in my experiences, if they can't solve the problems or help the family, they will recommend somebody who can. So there's been a lot of community focus and connectedness, as we talked about on the last slide, for people to be able to get to know one each other and know exactly what each company is doing as we work in these aging populations around the communities. Because if we don't, we really don't know how to answer your questions when you say, what do I do, when, and we have to fill in the blank. So there are public and private support resources for activities, nutrition, socialization, minor companionships to home health care, and so forth. So there are a lot of resources. So there's really the goal right now, I think, is to have as much connection as we possibly can and getting people connected to the right levels of care, even when they're inpatient and when they're outpatient. So the outpatient departments, of course, they have physical therapy and occupational therapy and rehabs and structured outpatient programs and so forth. So there's so many different levels of care that can happen on the outpatient level. And some of those are billable services through insurances, and most of the time that's going to be the Part B of Medicare plans they cover everything that we've got listed on the slide right here. Well, with the exception of the day services and life centers. So that's a stretch of the Medicare Part B. But if there's counseling and if there's exercise that is needed after cardiac surgery or an event, all of those things are available, and getting connected to that is very important to do to maintain ourselves physically and mentally. So there's different levels of care, of course. We have inpatient care, such as the Pavilion provides inpatient psychiatric care at the very bottom point there. And then there's inpatient rehabilitation. So if you're familiar with Williamsburg, Centera Williamsburg Regional Medical Center there, they have inpatient rehab for folks who complete surgeries on the ortho unit. So, it's all a continuum care model. Then the medical surgical hospitalization also is, maybe ICU or some type of observation when somebody is given the levels of care that's necessary. So there are many levels that people can receive the care, and it doesn't necessarily mean that it's mental health, but other folks are receiving mental health care in these types of settings as well. So inpatient psychiatric care, for us, it happens whether it's voluntary, involuntary, or through the Psychiatric Advance Directive, which is what we talked about earlier, having a family member be able to sign you in. And the biggest key component is making sure there's no medical reasons for the behavior first, and that there's capacity or no capacity to make decisions. Those are key points in regards to getting inpatient psychiatric care. And the difficult piece of that is that it's one of the types of hospitalization settings where we give up a lot of our human rights because we can't make decisions for ourselves. So we rely on others in that hospital setting, the doctors, the staff, and everybody around us while we're receiving treatment. We're relying on them to make the decisions for us while we have the psychiatric crisis in play. So it becomes a very, very difficult decision sometimes. We think, they need to be in a psychiatric hospital, but if they don't meet criteria, they won't be admitted because it just legally and ethically just cannot happen. It's a pretty serious event overall, but it's a necessary event to help people get through that moment. So a couple of cases to think about, and these are really quick because I know we need to wrap this.
Oh, okay, Gary. There's Gary. He's back. I was just letting everybody know that not to fear.
All right.
We were going to have it recorded, and people would be able to kind of tap in. Okay, well, you can feel free to go ahead and pick up. No problem.
All right, I'll wrap this up real quick. I am calling in on my cell phone, so hopefully you can hear me.
Yes.
Okay, so we were talking about the case of Mr. Mark, and so we'll review this real quick. Mr. Mark has been wandering on the road when family tries to get him inside a protest and has been physically aggressive with him. He has narrowly missed being hit by a car 3 times this month, and he's begun to be aggressive with his wife, which is very out of character for him, and his family physician has diagnosed him with dementia. So this scenario is actually a very real scenario. I can't tell you if it's totally true, but I think it's pretty close to some stories that we've heard before. But things that, over this evening's presentation, some of the things we maybe want to look at was, is he over-medicated? Is he suffering with a urinary tract infection? What's going on? Just because he was diagnosed with dementia and he's behaving this way doesn't necessarily mean that's what's causing his problem. And it's going to be very important as we work on Mr. Mark and everybody in the team gets together and works with Mr. Mark to kind of figure out really what's causing him to do this, because he's in an unsafe situation and he keeps getting himself into that apparently, and we have to find a way to get enough people around to give him a safe environment. All too often, things like this, the first thing to think of is, well, he needs to move out of his home and he needs to go to assisted living or memory care and so forth, but that's not always the case. We have to look at each one individually. The case of Mrs. Booker, In her case, she lost 10 pounds in 3 months without dieting. Since her best friend moved away, she stays in most of the time and seems down and not herself. This looks like a pretty clear-cut case of depression, but this is how simple it happens to somebody. Her best friend moved away, and now she's kind of withdrawn and becoming more reclusive. And she's losing weight, which means she's not eating as well as she's probably not sleeping well. That's another great question to ask somebody. And most times, someone like Mrs. Booker can do some outpatient therapy to try to work through some of the grief of her friend losing or her friend moving away, and some of the things that she can do to kind of redirect her energy and her focuses again. The only thing that we don't know about Ms. Booker, does she have a history of depression in her life? Is it untreated? Is it being treated now but not really managed well? So she has some things to work out, but in the general sense of things, this really looks like a depressive state, and this could be our neighbor, it could be a loved one, or anybody who's around us right now, and we may not really see all the signs as well. 2 more for you, I promise. The case of Mr. Maddox, he's been treated for depression in the past. He has tried therapy and medication with some success, and he's currently in a blue mood and can't pull himself out of it. He just sits at home all day. Again, another depressive disorder that really has a lot of indicators in this. One thing about Mr. Maddox that I didn't bring up earlier in the slide, but I'll bring up right now as a quick note, is that the most successful people who commit suicide are those that are really Caucasian males that are over the age of 70. So if Mr. Maddox is that gentleman over 70 and a Caucasian male, if he's in a blue mood and can't pull himself out of it, he has a history of depression, trying therapies and medications, this is somebody we'd really want to take some serious concerns on and really try to find an intervention and find some way to help him out. Maybe it's more therapy, maybe it's a change of medication, maybe it's even a short-term hospital stay with somebody like the Pavilion to be able to help him get through this moment. The major depressive disorders and people who have had it for many years really struggle with this, and so we can't take anything for granted with Mr. Maddox other than the fact that he may have a really serious underlying condition with intentions to harm himself or others, and we really need to take that as a serious look as to what needs to be done to help him. And then Mrs. Phillips has been taking a nerve pill, which is something we hear very, very often in our treatment center is Zoloft, let's say, and her family physician for over 7 years. She feels like it's not working now and has tried other medications, but they don't work or they have side effects she can't tolerate. So in this case, sometimes Mrs. Phillips needs a medication change. What we see sometimes in the hospital setting is actually a reduction of the medication. So as we get older, sometimes our physicians will try to increase the Zoloft, if you will, and that actually has more side effects than, obviously, she's stating that she can't tolerate those. So in this case, we might want to look at whether or not the medication is just too strong for her now because she's not able to process it as easily, and maybe it really is the wrong medication for her. Maybe she needs a dual medication treatment, maybe some more therapy, something of that nature. But all too often we hear people just say, oh, I've been taking a nerve pill for 7 years and it doesn't do anything for me. Well, that doesn't necessarily have to be the new norm of life, and things can change if we get you to the right levels of care, the right kinds of care that you need. And she's a great example of somebody who can be very happy once we can find the right types of stabilization for her to get her feeling better again. So wrapping all of this up, and I thank you all for your time and dealing with some of the technical difficulty there, but it's really important to look at the bio, psycho, and social approach. All 3 levels have to be looked at when we're talking about aging well in a mental health perspective. Learning how to make adjustments in our life as we get older is extremely important. Considerations of all of our resources that are around us and utilizing those resources. And still striving for autonomy and hope, empowerment, and connectedness of the person and with other people around us. So my last departing gift is the homework piece, like I said, which was to go home and do your advanced directive. If you have the opportunity now to update your advanced directives and get some new wording in there, and again, if you have one in the state of Virginia that's older than 2009, it doesn't have a mental health component in there, and we highly recommend and encourage that that happens. And so if you should ever need that, at least you have that component that's written in there that can help you and your family members in a moment of crisis. All too often the crisis happen, and that's not really the best time to figure out how Virginia right now handles mental health. So with that being said, I thank you all for your time. If there's any questions that I can answer for you, please feel free to let me know. And I will turn this back over to Ms. Janae if there's anything she would like me to do. Thank you all.
Thank you, Gary. That was an excellent presentation. I know our listeners and viewers enjoyed that and got some really good information, even just about the advance directive, about that mental health piece. That's not something that we hear too much about, so that was excellent.
Right.
I thank you for your participation and your willingness to share. And if you want to type in, Gary, any of your contact information, if people might have questions later, you know, people always kind of rehash and think things over and they say, oh, I forgot to ask or I should have asked. I'm sure they would appreciate being able to get a hold of you. And with that, we are going to come to a close, and we thank you all for being patient with us in spite of our technical difficulties, but that's technology. And when it works, it's good, and when it doesn't work, it can be bad. So, but the presentation has been recorded, and it will be available in the next 24 to 48 hours. You can go and like us on Facebook at Carekeepers Inc., and the update of when the presentation is available to be downloaded will be made available through our Facebook and Twitter page. So until we meet again next month, thank you all for your participation, and keep an eye out for our upcoming, I think we're doing fraud prevention for seniors next. So that should be a very interesting topic as well. I think it's going to be Marley Flores from the Richmond, Virginia office of the fraud prevention. So keep a lookout for that invitation, and thanks again, and everyone have a great evening.